This is part 2 for weeks 8 and 9, molecular genetic testing. Next gene sequencing, NGS. The NGS technologies dispense with the Sanger technique and capillary electrophoresis methods, referred to as first-generation sequencing, in favor of sophisticated parallel formats, which are called simultaneous reaction formats, to synthesize DNA from tens of thousands of identical strands simultaneously and then use state-of-the-art fluorescence imaging techniques to detect new synthesized strands and average sequence data across many molecules being sequenced. Please go to the video to see next gene sequencing. NGS technologies are providing an unprecedented capacity today for generating massive amounts of DNA sequence data rapidly and at dramatically reduced costs per base. In looking at cancer for just a moment, if we looked at the way that we used to approach testing, if we were looking for someone, whether or not they had a gene for hereditary breast and ovarian cancers, we tested by looking for BRCA1 and BRCA2. For hereditary colon cancer, for Lynch syndrome, we looked for MLH1, MSH2, MSH6, EpCAM, PMS2, PYH. And for polyposis syndrome, we looked for APC. This was previously done in a sequential manner, stopping if a mutation was detected. It's important to identify patients at risk for other breast cancer syndromes involving other genes, and multi-gene panels are increasingly being recommended. For example, they could be looking for TP53, PALB2, and PTEN. Knowledge of these other genes can influence radiation therapy and chemotherapy decisions. In looking at multi-gene panel testing, the genetic testing has expanded due to the new technology utilizing next-generation sequencing, NGS. This technology allows for the rapid and inexpensive analysis of large chunks of the genome. Multi-gene panels allow simultaneous sequencing of many genes associated with a specific family cancer phenotype or multiple phenotypes, and includes intermediate penetrant genes of unclear action. Multi-gene panel testing is more cost-effective and time-effective than sequential testing. It can reveal more than one pathogenic mutation. This slide shows that many genes can contribute to hereditary cancer. At first, you can see that multiple genes can increase the risk of a single cancer if we look and see all the genes that can cause breast cancer. And then we can see that multiple cancers can be associated with a single gene, as we have in the other part of the slide with the TP53, where we have all of those organ systems that can be affected by the TP53. So by looking at additional genes, there's been approximately a 46% increase in mutations detected by analyzing the additional genes in the hereditary breast and ovarian cancers. We also see that there's considerable overlap in the genes and how they affect different systems of the body. And if one was to do a management of a patient, it'd be very important to know exactly what systems can be affected. Today, those patients who had breast cancer who were found to be BRCA1 and BRCA2 negative are getting update tests to look at these other genes that are associated with breast and ovarian cancer. So with a positive test result, if identified, there's an increased risk for certain types of cancer. There's different mutations are linked to increased risks for different types of cancer, and the risks may differ for the different mutations. Some are very high, others less, but still more than the general public. Individuals who receive a positive test result may be offered special or more frequent cancer screening exams to find any cancers that develop as early as possible. It's going to be dependent upon the specific mutated genes. Originally, there were concerns that some mutations on multi-gene panels have no clear guidelines about the best screening exams to use or how often. However, the NCCN guidelines are increasing. With this new technology, we are finding that there are VUSs or variants of uncertain significance seen in many patients, both affected and not affected. These are single nucleotide DNA polymorphism that are neither confirmed benign nor pathogenic. The rates are going down though, and there are ACMG guidelines and lab data available. And the data is kept by the lab that has done the test of whether or not there is a VUS, and there are times when a VUS has been shown to no longer be benign, but is now pathogenic. In 2016, at the National Society of Genetic Counselors annual meeting, there was discussed a Stanford study on hereditary cancer panel tests. And there were 3 recent publications from an ongoing Stanford prospective study utilizing 3 different cancer centers in California. At that time, they were still enrolling patients with a goal of 2,000 participants to undergo genetic counseling and panel testing. Those individuals in the study were both male and female, had a minimum age of 18, and they had no prior testing, genetic testing. The 3 studies were: number 1, favorable psychosocial outcomes in high or moderate risk mutation carriers identified by hereditary cancer panel testing. Number 2, safety of multiplex gene testing for inherited cancer risk, interim analysis of a clinical trial. And 3, yield of multiplex panel testing exceeds expert opinion and validated prediction models. It's important to remember that the multi-gene panel testing allows simultaneous analysis of multiple high and moderately penetrant genes. Some providers feel that testing moderate risk genes may lead to patient confusion, given limited understanding of the penetrance and expressivity. Current screening guidelines for moderate risk mutation carriers rely heavily on expert opinion. So in this study, the outcomes were measured at multiple time points. They began the measurement 3 months after the disclosure of the genetic test results, and a multidimensional impact of cancer risk assessment, a microtool, was administered with the 3-month follow-up survey. This tool measures the specific impact of result disclosure after genetic testing. It measures distress, uncertainty, positive experiences, 0's never, 1 is rarely, sometimes is 3, and 5 is often. The genes included in the panel were the following genes. I'm not going to go through all the names of them, but you can see that this was the multi-gene panel that was utilized. Of course, you see the BRCA1, BRCA2, here, PTEN, and the TP53, as well as the APC. In the interim analysis, which was performed on 9/9/16, of the 1,793 enrolled patients, 1,430 were sent a 3-month follow-up survey. The response rate was 59%. Among the respondents, 11% tested positive for a mutation. The 90 mutation carriers were included in the analysis. So 90 out of 842 were positive. 90 mutation carriers were divided into high-risk and moderate-risk mutation groups, and their means were compared between the groups using t-tests. Looking at the demographics of the patients with a mutation, of which n is equal to 90, 44% were Hispanic, with a mean age of 50.8 years, 70 patients, women, 25% spoke only Spanish, 38% had a high school education or less, 25.7 had no history of cancer, and the most common cancer diagnosis, breast 30%, 27 cases, colon 20%, 18 cases. The mutations that were found in the high-risk group was 53 patients, and those genes that were in the high-risk group, APC, BRCA1, as you can see from the first chart here, and then the moderate risk group, of which there were 37 patients, APC, BARD1, etc., as you can see from this sheet. If we look at the moderate risk mutation carriers, they did not have higher levels of uncertainty or more difficulty in making decisions than high-risk mutation carriers. High-risk mutation carriers had a slightly higher level of understanding of their choices in cancer prevention, but not statistically significant. The p was equal to 0.062. Both groups rarely experienced negative feelings such as sadness, anxiety, regret, or problems enjoying life. Both groups showed very strong desire for information and a very high level of trust of the results from the genetics team. More individuals in the high-risk group wanted to know about genetic test results related to only the cancer types in their family. And looking at an additional interim analysis in regards to the safety of the multiplex gene testing for inherited cancer risk, we see there were 1,000 patients, of which 818 were females, with a median age of 51, and 89% were positive, 420 were negative, and 309 individuals had a VUS. The most common cancers were breast cancer in 37.6% and colon, which is 15.9%, and 20% of the individuals had no history of cancer. In this study, and looking at the perceptions of the genetic testing, the majority of participants wanted to know all test results, rarely thought of cancer that affected their daily activities, and never regretted learning about their test results. There were no differences between test result groups. There was little evidence of harm at this interim analysis, and prophylactic surgery rates are low, and few had intrusive thoughts or regret. All individuals who were found to carry a VUS or were negative only underwent surgical procedures for cancer treatment. In those that tested positive, one had a hysterectomy and one had an oorectomy for preventative reasons. The microscores of distress, uncertainty, and positive experiences of mutation-positive patients differed significantly from those of negative patients and of VUS patients for all microcomponents. The microscores of the VUS patients did not differ significantly from those of the negative patients for any of the microcomponents. Differential diagnoses were generated after expert clinical genetics assessment formulated up to 8 inherited cancer syndromes ranked by estimated likelihood. Of the 818 females in the study, 37.6% breast cancer and 15.9% colon cancer. 26% carried pathogenic mutations in genes not included in the experts' differential genes. This suggests a significant contribution of expanded multiplex testing to clinical cancer risk assessment. There is a potential for clinically meaningful outcomes when the added value associated with the assessment of multiple genes. In the conclusions from this study was the identification of unexpected mutations broadens our understanding of cancer risks and genotype-phenotype correlations. This study demonstrates the need for increased awareness and utilization of genetic testing for detection of cancer syndromes. And it demonstrates that multi-gene testing can be carried out in a diverse population. And looking at some of the limitations and questions that were raised by this study is the follow-up time is short. It's only about 3.3 months. And will the rates of prophylactic surgery, distress, and regret rise? And what will happen if or when the VUSs are reclassified? Another limitation is that the information on relatives testing was reported by patients. It's not verified by direct report of relatives or review of their test results. In the future, we want to complete the enrollment in the study up to about 2,000. We want to do more long-term follow-up, use of medical management and chosen interventions. Surgery and screening use over time will be studied. Yield of procedures such as cancer detection, subsequent intervention, and survival. Focus studies of other care settings, patient relative, are warranted. For example, in a general oncology practice. And what do clinicians say versus what patients and relatives actually hear? I'd like to discuss a current study that I've been involved in for a few years and with a specific family with a Lynch syndrome. Now we have this one person who is the nephew. So it's a Lynch positive nephew of the proband, his maternal aunt, and he was diagnosed with colon cancer at 35 years old. He had bladder cancer at 55 years old. His father died of mesothelioma. His mother had colon cancer. She was Lynch positive. Paternal grandfather had pancreatic cancer. And it's believed that he has paternal aunts who had breast cancer. However, this was not confirmed. So when we look at this patient, the patient that we're looking at who is Lynch positive, we tested his children, and his children had single gene testing, and they were all found to be Lynch negative. And then his eldest daughter was diagnosed with breast cancer, and she had a mutation on the PALB2 gene, specifically deletion exons 11 through 13. Her father was found to carry the same mutation. We tested her two half-sisters. One was positive. Her positive sister had a prophylactic double mastectomy. Now we're testing more family members for the PALB2 gene. If there had been a panel test, we would have been able to pick up the PALB2 gene at a much earlier time. So we then believe that the PALB2 gene came from the paternal side of the patient's family, and the maternal side is where he had the Lynch syndrome. Now, in an individual who has the PALB2 gene, there's an increased lifetime risk for breast cancer and elevated risk for pancreatic cancer. And the ovarian cancer risk is currently unknown. The breast cancer risk is 17 to 58% up to age 70, and the pancreatic cancer is unknown. It's greater than 1% of the general population risk. For the PALB2 recommendations, you would say to do a self-breast exam and to have examinations of the breast every 6 to 12 months, and to consider MRI in addition to mammography. To look at the pancreatic cancer risk, it would be individualized. You could consider EUS, MRI, MRCP, and you could enroll in a clinical trial. You would refer this patient to a high-risk breast clinic, and the Ovarian Cancer Association at this point, studies are pending.